I think there are some issues that related to the consensus statement. So rather than presenting, we can, if we both agree, if we three agree, that just raise the issues and discuss them. Do you think? Yeah, I made a small list. We didn't have a chance to check things, and so we'll have to have it in interactive. But I made a small list of points, and I think the two speakers also can raise the points. I think maybe the first one is, I mean, your organization is doing very well, because I see that the patient, actually, I see my patient coming and they know a lot more about neuroendocrine disease, and it's sometimes a problem because they tell me what to do, so it's a problem. But it's otherwise, essentially, but the real target is the doctors. There is a lot of physicians that have no clue about all the implications of everything you discussed today. So maybe this is one of the first questions. How do we get to the medical profession, or the not only the medical, the nursing profession and so on, about neuroendocrine tumor?
I think this is a real problem because of such a low incidence disease, and physicians' lives are already being so complicated. If you don't tend to see things, you don't tend to think of it. And I used to say that probably most family physicians would get through a whole practice lifetime without ever seeing one of these tumors. You can send them out information, but if they don't see them, it won't stick. The information will be lost. I think mainly what we can hope for is that physicians realize that this is not something that's usual, and refer them on to people who deal with these more commonly, can recognize them and determine the management. But it's a real problem with the complexities of life, the limitations of the human mind, that all these complexities of disorders can be fixed in the mind of a family practitioner. I think it's almost impossible.
Mm-hmm. Dr. Müller-Brand, from the European perspective.
And there are two groups of patients. One are the patients with functioning, and the second group is non-functioning tumor. And you will probably never find a non-functioning tumor only by chance. I can remember a surgeon. She was a young lady, and she was working in a hospital in an emergency unit, and there was no emergency. So she lie down and she tested a new ultrasound device on herself, and she had discovered liver metastasis and got a biopsy, and she got a neuroendocrine tumor.
Yeah.
So I don't think you will find the non-functional tumor other than by chance. The other are patients having symptoms, and as is with any rare disease, it's you have to educate the doctor, and to make more public work to bring the people in the mind, if they find something which is unusual and it didn't fit in the normal scheme and to the normal disease, to think also a little further. And if you as the Americans say, if you hear the horse beat, think not only on horses but also on zebras, and it is something which the people, the doctors, has to have to got in their mind.
Yes. The other issue is the issue of evidence-based. It was raised earlier that we get into problem with agencies, not only with physicians, what they do, but also agencies who fund the drugs and other things, and they want level 1 evidence so that they can agree to put the money for it, or to allow the physician to use the drugs or the procedures or the tests. Now, I've been involved with the GI guideline in Ontario for nearly 10 years. I'm not anymore. But evidence-based medicine is abused, because what evidence-based medicine says, you should look at the evidence and then use the best evidence you can have to decide on what to do with the patient. Now, a colon cancer is very easy to get level 1 evidence because you have hundreds of patients. You can do studies. You do thousands of patient studies. Neuroendocrine tumor it's very difficult. And actually, the PROMIT study is an amazing event, because we have a study that showed something, level 1 evidence of some event. So I think we have to get the message that we have to sometimes use the best evidence we have to make decisions, rather than just say, I don't have level 1 evidence, then you shouldn't do it. Actually, they should also say, those who use that term should say there is no level 1 evidence that it doesn't work. It's not enough to say there is no level 1 evidence it works. They should say also the level 1 evidence doesn't work. Yes. Yeah.
Maybe just to reinforce that point, every specialist in the room is familiar with the name of Dr. John Parbasing, who was the man at the Royal College who set up the system of CME credits by which we keep up our medical education. And I heard him speak a couple of years ago. He's out of medical circles now, nominally retired, but consulting. And he says, evidence-based medicine is yesterday's paradigm. It didn't deliver the goods on time. And the paradigm going forward has to be evidence-informed decision-making.
Comments from the panel?
Yeah, I think that's very true and a very good way of putting it. Nonetheless, there's a fairly large group of physicians that have elevated evidence-based medicine into, well, it's really a religion in medicine, and I think that is very disadvantageous. I'd also like to point out that not only is there a problem with the numbers of patients, and to do evidence-based type of studies with prospectively randomized control studies, you need large groups of patients to get that statistical power to show differences, and you very often don't have that. The other problem is a lot of these tumors are very long-lived, and in order to see an endpoint or event occurring for these studies, you may have to wait a long time. I think our experience in GI cancers and colon is that, gee, if you're not getting results within 3 years, the study usually gets abandoned. And some studies one can envisage doing in neuroendocrine carcinomas can take 10 to 30 years. It might take a person's whole career or lifetime to do it. And who's got the patience and forbearance and support to do that sort of thing? So I think that for a lot of situations, we'll never rise to that level 1 of evidence that is demanded by the evidence-based priesthood. We really have to go on the best evidence we have on hand, and can't wait for level 1 evidence to occur, because it might not actually ever be done.
Yeah. Doctor, any comments?
The evidence-based medicine in such a rare diseases and the orphan disease like neuroendocrine tumor is something which was founded by bureaucracy, and the problem of the worldwide problem at the moment is that we have too much bureaucracy. And I mean, if you have a new treatment modality, you don't should ask the bureaucrat, but you should ask the patient, and the patient will tell you what they like. Yeah. And even if you have a bureaucrat and he got a rare disease, then he's the first who is crying to get a new treatment modality without any evidence.
Yeah. Ki-67 is we had some problem. I'm just raising some issues in Canada now. There was a time, or you still get patients with a diagnosis of neuroendocrine tumor. Actually, maybe pathology in general. Sometimes they don't really tell you that it's well differentiated and so on. They go into the detail, and if it's often you don't get the Ki-67, and with that, then we have to go and ask them to get the Ki-67, and we get messages. First of all, you have to fill a form, and then who's going to pay, and then which part of the sections you want to assess, and so on. Is anybody has any problem with Ki-67 anymore in Canada? Or any comments from pathologists or the panel?
If you're in a smaller center and this happens to get diagnosed by surgery because you're in a smaller, especially non-academic center, very often you won't get this done. In spite of efforts we had through our pathologists groups to promulgate this, although it's probably known now in most academic centers, you may not necessarily get this and still have to go through the request to get this done. In addition, we generally find that if the diagnosis is made by what's called a fine needle biopsy, the amount of tissue that's obtained from fine needle biopsy or fine needle aspiration, which really amounts to cytology, cells spread over a slide, is insufficient to do this. You really need a larger, at least what's called core biopsy, a larger amount of tissue. So we're really very much pushing for people to get biopsies that produce sufficient tissue for us to do these determinations as well.
Any other comments? What about chromogranin? If I want to have chromogranin in Ottawa, I cannot get it. It's interesting that I discovered that the endocrinologists can get chromogranin without any question, but we don't. And then we send it. Yeah, this is not fair, is it? And then you have to send it. Then we found that Montreal does chromogranin, so we wanted to send the sample to Montreal and get the message from the hospital. Say, well, who's going to pay for the sample to go to Montreal? So we still haven't got the ability to do chromogranin on a regular basis. Though one of my colleagues last week sent me an email because he asked for chromogranin, and either the person there was sleeping or didn't take any notice, but he got it. He got the result. So it's very haphazard. Now, Dr. Oberg was visiting, and I think there are data from that chromogranin is becoming a very important test to do. So any issues in that sense from the Canadian and the European?
I think there's a whole lot of issues, there. Chromogranin A is actually a complex molecule, and it's a pro-molecule because it splits off into other smaller molecules which have their independent activity. One of the problems that we have found, because in London we can get chromogranin A done pretty routinely, but the problem is which methodologies, and there's about at least 8 different methodologies in the world that exist. We have fortunately been able to secure funding and are starting in January a study whereby we're going to do chromogranin A by several different methodologies and compare them both in patients who have neuroendocrine tumors and in a normal population. And as well to find those things that affect the chromogranin A. The methodology, however, seems to be very much dependent on what part of the chromogranin A molecule is detected by that particular methodology. And if it's only part of the molecule, you can get very disparate, inconsistent results. The best results seem to be obtained from those methods that actually are able to measure the whole molecule, not just part of the molecule. In the North American Neuroendocrine Tumor Society meeting just 6 weeks ago, it is seen that that a breakout product called pancreastatin is now being utilized increasingly in the States, and the claim is made that if the chromogranin A is raised and the pancreastatin is not, it means it's probably not an effect of neuroendocrine tumor. So pancreastatin may become into the fore. And now there's an interest, especially in Europe, about looking at chromogranin B, and yet another molecule, and some people are speculating or conjecturing that this, in fact, may turn out to be more specific than chromogranin A. So the whole field, I think, is in a rather dynamic state, and it's very difficult to determine what's happening to diseases just based on chromogranin A itself. It doesn't stand by itself. It has to be utilized in conjunction with considering other factors and other results to make much sense out of that. And we really need to find out what is the best or the most reliable or valid methodology to do this. And I think it also begs a whole other question, and that is the type of neuroendocrine carcinomas that are from the pancreatic endocrine group can produce a whole number of different proteins or neuropeptides, as they're called. Some of them are functionally inactive, so you don't suspect the patient has them elevated because it doesn't cause a corresponding clinical syndrome, but they can be elevated and useful as marker substances. But we can't get hold of them here, and I've been suggesting and actually militating for a center in Canada by which all of these special markers can be done with the expertise, because they're done frequently enough that we can send them to. This, of course, would need recognition and funding from governments, and you know how anxious governments are to fund things, especially these days. So it is a real handicap we have in that we can't get all sorts of markers done. There is a particular substance called VIP, vasoactive intestinal peptide, that produces terrible diarrhea. And in few patients that have this, it's a terrible problem to get this done. You have to arrange for it to go to the States, and maybe months before you get a result back on that particular substance. We're really very much handicapped in getting some of these marker substances. And chromogranin A, as I said, is a particular special problem for those considerations I've already mentioned.
Dr. Moore, any problem in Europe for chromogranin, or the value or the test?
Not so many problem like our Canadian colleague, fortunately. But I feel the chromogranin A is very valuable as all tumor marker in follow-up. And I mean more than for diagnosis. And if you make a follow-up, it's necessary that you are using the same technique and the same methodology as stated before. And I recommend in patients who came to us with an elevated chromogranin A to use it as a tumor marker and make the estimation every 3 or 6 months. It depends on the referring physician. With chromogranin A, one must be careful for the follow-up because the chromogranin A level is dependent also on the kidney function. And sometimes patients are referring to us with a chromogranin A increase as a suspect for a tumor recurrence, and then if you make a comparison with the creatinine, you can see that the patient has a mild renal failure and that the chromogranin A is not increasing because of the tumor, but is increasing because of the increase of creatinine. This is something which should be stated.
I think also the protein pump inhibitors can influence the result, and
yes.
It's very widely used by physicians without any control.
And I also agree that as a tumor marker, pancreastatin will probably be useful in the next year, but at the moment it's only used on one center in the United States and not commercially available.
What we like to say in Ontario is that protein pump inhibitors in funding by OGB, which is only for patients over 65, the province spent $90 million a year just to do that, and it's prescribed by every physician who wants to without any kind of control. And that's only for the OGB funding, and if you look at the whole of systemic therapy in Ontario, their estimate is about $200 million cost, the whole systemic therapy, including hormones and so on. So this is a perspective to keep in mind. An issue was raised earlier about octreoscan is that, and we have raised that in our guidelines, in our consensus in Canada, is that if you don't use the right dose, you might not get the best test. And somebody mentioned that some of the discussion earlier on imaging was made. So how important that is in a sense, and should we really have a strict guideline about how to do the test, what dose you should use, the exposure, and so on? Any comments from the imagers?
Octreoscans scans. We are guilty of splitting the dose in two, but we prolong the imaging time per patient because we're giving a fixed amount of budget to do the patient to image patients. We want to help as many patients as we can as possible, and by imaging with 3 millicuries, we have very good sensitivity when we image for almost twice as long.
So are we missing cases? I mean, has it had clinical implication, which I suspect it is, but...
Yeah, we have pretty good results, but we don't have any gold standard to compare with.
Yes.
You know that we're supposed to be using these techniques according to the recommendations, and because the test is only funded at half the level it actually costs, well, the institutions insist that you only use the half dose. This is not a problem in the States where they use the full dose. It is a problem here. In London, we're fortunately able to do a full dose scan because we can obtain material from the therapeutic amounts we have in excess and can do that, but almost nowhere else in Ontario is that done. I should also mention that it is the expectation by those who, by the neuroendocrine treatment community, that in the next 5 years, that what you heard about earlier, gallium-68 octreotide scans will probably take over because it's probably a fairly bit more sensitive. But I'm not sure whether it was mentioned that in Canada, It's only approved for animal use. We can have generators, but we can't use them in people because of Health Canada regulations.
I don't think we should say that last point, because my sense from Health Canada is if we made a compassionate plea that they might, under some circumstances, I'm not sure if that generator would be approved, but they are talking about compassionate use of gallium-68. So we need to find out more about that. But to just come back to the octreotide scans, the issue we've run into in the community in Ontario is that the doses are being halved and the imaging time is not being lengthened. And I know that our colleague Dr. Reed has had some discussions with people, and they have basically refused to lengthen the imaging time. So then what has come back to me from questions at other levels across the province is, well, you know, how important is the octreotide scan anyway? Our oncologists say it's not that helpful. And so you get into a downward spiral where it's not being used. First, it's not being used as it should be, and then it's not being used.
Well, I think there's very clear-cut indications from the consensus group that is probably one of the most valuable imaging techniques we currently can access. So I'm not sure which oncologists are being asked, but I think to those of us who actually treat the disease, it is very helpful. It can help us determine whether we should go to a regional therapy versus a more systemic therapy, whether surgery can and should be done in certain cases. Are we missing other disease we can't otherwise detect? It is highly useful, and it's a standard.
Last two questions. Should we use octreotide LAR for patients who have high 5-HIAA to prevent heart disease? Because there was a big debate among the Canadians. And the second one, coming from the PROMIT study, a patient who's asymptomatic that progressing or not progressing, should we use LAR, octreotide, in that context? Finally, could you go further and use it as adjuvant? Though maybe we should do a study for that, but Dr. Muller.
Yeah. I think we have not, if we go back to the evidence, we have no evidence that somatostatin LAR will prevent the cardiac disease, especially the tricuspidal valve disease. But if I should make the decision, I will say yes, you should use it. And because sandostatin is well tolerated, the only problem of sandostatin is the problem of cost, but probably the sandostatin price will go down within the next 2 years after the patent will be out.
Do you accept the notion that high 5-HIAA is predisposing to a cardiac disease? I mean, and that
I don't know.
Okay. And what about PROMID?
And the second question, I think PROMID data has shown that sandostatin LAR is well helpful in patients with low tumor load,
liver,
especially with a liver involvement of less than 10%. And if you have, and most of our patients has a bulky disease, huge involvement, and so far probably there's no positive effect.
Would you give it as adjuvant after you resect tumor? Adjuvant after you resect metastasis if you extend the low tumor load?
Well,
I know it's a provocative question.
It's an economic. It's not a question. Medical question is an economical question.
Yeah, okay.
If you can afford it, I will do it.
Okay, Walter.
Well, I think, as Jean knows, I've been a very strong proponent for utilizing an amount of somatostatin analog to try to suppress the production of 5-HIAA for heart disease. When I started out doing this about 15 years ago, the rate of carcinoid heart type of complications was about 40% in the patients that I saw. We have a lot of indirect evidence that serotonin is a major contributing factor for this happening, and there's also some indications that it isn't the whole story. There may be other factors that are involved with it all, because everybody who has a high 5-HA doesn't necessarily get it. Nonetheless, we've been able to identify serotonin, and I would believe that if you can affect just one of the factors, like serotonin, you can very much affect the whole disease progress. So I've been a proponent of titrating the dose of somatostatin to try to get the 5-HI level down to as close to normal as we can. And over the years I found, boy, there's a lot of patients I can't get it down to that level. Some I can, but eventually they escape that and they rise. Nonetheless, it's been my impression that the rates of the carcinoma of heart disease has really dropped, and I have the notion that maybe just treating this fairly aggressively, not necessarily reaching a point where the 5-HI levels are to normal, may be sufficient to very much affect the incidence of that particular disease. With respect to the PROMED results and utilizing this as adjuvant therapy, I think there's two ways of looking at this, and at the present time, both of these may be valid. If as an adjuvant therapy, and especially people who have had metastatic disease resected, I usually keep people, because they've usually been on it at this point, I usually keep people on it, even though the surgeon says, okay, we've cleared all the disease, you don't need this anymore, but I have the sense that there's probably other microscopic disease around that can be suppressed by the somatostatin, and if the patients are not having any problem with it, I'll keep them on it, or if they've not been on it, I will often put them on it if after explaining to the patient this is something they wish. The other approach that is probably valid as well, as expressed by some people, is, well, you keep a close eye on the patient, and if evidence of the disease occurs, then you put them on the somatostatin analog, because that's where the PROMED study showed its benefit, that it very much increased the time to progression. So right now, it would appear that either approach is probably a valid approach. We don't have any data or information to pick one over the other, and it may be a matter of both physician and perhaps patient preference.
Can I have one more question? No? There is a band playing behind us. Okay. Well, there is a rising incidence of carcinoid syndrome according to the data. Is it real, or is it just better diagnosis? The incidence.
Incidence of carcinoid syndrome?
No, neuroendocrine tumors.
Oh, that's a hard one.
You see graphs.
We suspect that the increase is so large that it probably is. Since you saw the graph, I think, earlier that I produced with respect to Ontario, and it's gone up tenfold.
Yes.
How can you get a tenfold just by detection bias? I'm not sure you can, especially in an era in early years where there was a mandated autopsy rates to maintain certification for medical schools. Now that's been dropped, so there's less autopsies than ever being done before. So incidental tumors are found a lot less. And there's also some indirect animal evidence that I think it was in the 80s, some pharmaceutical company fed a PPI, proton pump inhibitor, like omeprazole, to a cohort of about 100 guinea pigs for their lifetime. In a similar cohort, they did not. And interesting enough, they found that when these animals reached the end of their lifespan and were autopsied, they found 3 of the guinea pigs had neuroendocrine tumors found, and none of the control group had any neuroendocrine tumors found. Okay. So there is evidence, and a lot of it is preclinical animal, and there's some indirect evidence to indicate that there may be a role of anything you do to make the stomach atrophic, whether it's ranitidine, the H2 blocker, or proton pump inhibitors, will have some sort of feedback mechanism to stimulate neuroendocrine cells, and this may predispose to increasing the rates of neuroendocrine tumors, because it's one of the very few tumors or cancers around that's increasing in incidence. Most of the others are steady or dropping.
Mm-hmm. Final answer, Dr. Muller-Brandt.
I think it's a better diagnosis that a real increase in tumor incidence. That's my opinion.
Okay. Thank you very much.